Dental Implants, Process of Care, is presented by Anna Louise Tolan, RDH.
Good day. We're having another session together regarding what you should know about implants. Today we're going to focus more on the process of the implant therapy. So we are going to review, however, all the things we talked about last day. I wonder if you've been thinking in between time about different clients of yours that you have been seeing, that you are now planning ahead, sowing the seed, having some future care thoughts about where they're going to end up, and if you're starting to educate them on the choices that they can make when perhaps they lose a tooth, perhaps filling a space that has already been vacant for a little while. So our challenges that we identified last time are our current care plans that we are ongoing. Maybe something comes up in a crisis mode that is prompted by maybe an endodontic issue or a periodontal issue. And of course, assessing the future care needs for our clients. And then we were going to start to educate our clients on options and potential options, that there are consequences for having an edentulous site, and if we continue to add to those edentulous sites, then the possibility of decreasing their nutrition becomes a real concern. So then, of course, our next challenge as professionals is to stay current with protocols and guidelines to do the right thing, assess things properly, and when we find something that is not working out well, that we identify that. So we're going to go through some of those issues today. So I thought I'd actually start with a particular crisis that happened to a particular client so that you can follow it through and see how protocols and guidelines guide us into gaining information, and how we then have time to educate our clients on making choices about where they have difficulties and gaps in information that we can help fill things in for them. So this is radiograph of the lower right 4-6 we're going to discuss today, and this particular one was taken in 2005 when things were okay dokie. Yes, things were under repair, and the endodontic lesion had been dealt with, and a crown had been placed on top, and we were satisfied with what was going on at that time, and there was no pain involved. And all of a sudden we come fast forward to September of 2011, and our client shows up with pain and swelling, as you can see, and something's definitely going on there. And unfortunately, we had to then evaluate what are we going to do next. So then we end up with a differential diagnosis, because there was no true flag telling us what exactly was going on here. There certainly was swelling and pain, and that would be part of the chief complaint. Then we had to do a periodontal evaluation, which did encompass definitely pocketing on the lingual aspect. It had pocketing before, so we weren't quite sure if we were dealing with cracked root or a further endodontic situation or a periodontal situation. We reviewed the dental history of this tooth. We also looked at the review of the adjacent teeth so that we could see what encompassed our concern in that area. So as we present all these findings to our client, we discussed all the possible options, which was, basically to send her off for an endodontic evaluation, a periodontal evaluation, or we are going to extract that tooth and then recommend implant placement, or yet another option that was offered to her was to have it periodontally debrided here by myself and see if we get any more definitive action. We talked about doing all of those different options, the option of implant, and she certainly was not ready to say goodbye to this tooth just yet. She really wanted to save it, and so we tried the most conservative thing possible, which was to treat for an periodontal abscess lesion. So one of the things that we did discuss also was comparing the cost and the pros and cons of implants to a bridge. So there's a great slide here that you can review that has all of the comparison points that you want, are great discussion points about talking about bridge placement versus an implant placement. And in her particular situation, because the 4-7 already had a crown on it, it would be be more costly to place a bridge. So anyways, the long and the short of it is that at this time in September of 2011, the client was not ready to proceed with any definitive treatment. So the definitive treatment that was chosen was this treatment of the periodontal infection. So we had some local anesthetic put in, and I debrided that area. Some antibiotics was prescribed, understanding on the other side, our client is very overwhelmed. They're wondering about if this pain's really going to go away. Are we going to be successful with this treatment? They're trying to synthesize information about the implant, the cost. They're thinking about all these barriers. There just is a multitude of information in the sea of their mind, trying to decipher which treatment plan am I going to choose. So I think in this particular case, it was a great choice for her. Certainly upon the debridement, I did let her know, it could not work at all. She may be still in pain. It may not resolve in the least, or it might resolve quite a bit. We may just be buying a little bit of time. So with that understood, then we look at July of 2012, and things are not looking too badly. Yes, there is some inflammation and infection going on the distal buccal corner of the 4-6, but with further debridement and kind of coaching the whole situation along, it does continue to get better. And then we look again at September 2012, and the situation is looking quite great, but we are still discussing the possible outcomes that may arise in the future with this tooth. So in this time, she's coming back and asking more information about implants and the process and the costs and who's involved and what are the steps and how long does it take and what's going to be there in the meantime, and all kinds of great questions. And so the client has time to build information and feel more confident. So unfortunately, here's another shot in December of 2012, and we can still see that on the lingual aspect tissue, it's still looking quite good. So we have been successful, but we've only been successful to a point, because the client then does come back in February of 2013, and we've had a reoccurrence of swelling and pain, not to the same extent as the initial visit. However, it is still present. So the client has now had time to really think about all this information, and has had time to get used to the idea of what's going to happen next. And the client actually presents going, I'm ready to have an implant now. So let's just get on with it and have this tooth removed, and I know what I have to do next. And in this particular case, we were sending her to the oral surgeon to have that tooth extracted and the implant placed, because it had everything done to it could possibly have done. And so we were aware that most likely this tooth was cracked and fractured, and we wanted to make sure that as much of the bone that was available to be used was left intact. So this is a successful story of discussing, educating our client so that they may choose a treatment plan over time that became more comfortable to them. So she's able to verbalize the benefits she's going to have from this implant, that it's going to support the rest of her teeth, and that she doesn't have to do any further work to any of her other teeth. So it's all around great situation. So now, as we're proceeding to implant therapy, you know, our client is now ready, and we review the process with our client ahead of time so that they know step by step what to expect, and let them know, okay, the next step is going to be a surgical consult. Always try and while we've discussed the process of the appointments that are upcoming and the events, whatever that may be, whether it's even the simplest thing of planning sanitative phase therapy, when you present the entire situation, and then you must break it up for them, okay, your next step is. It makes it so much easier in the sea of information you've given them that they know, okay, this is my next commitment. And so we have the process that we've discussed with our client, that they're going to go meet with the oral surgeon with their radiographs, and that they can bring any of those questions that they may have to them so that they can go prepared, knowing that there should be a good open dialogue. So then our responsibility comes into play here, because we're going to do a risk assessment. It is essential for the success of the implant to have done a risk assessment so that there are no surprises. A little note about dental insurance. Now, dental insurance is a thing we have to live with, unfortunately, and sometimes it's much easier if the client's already run out all of their insurance, so that's not even a part of the equation. And for those people who don't have insurance, it seems to be easier than the endless battles that we fight with dental insurance. So some of them are going to be able to access funds from some flexible account. Some of them are going to be able to apply an estimate or a predetermination for a bridge or a partial, and take the money that they would have been given towards that and be able to apply it to an implant in the post treatment phase. But on the other hand, you have to watch for clauses that some of them put in. For example, one of my clients was allowed to use their flex funds for their implant, but they would not do any or cover any dental treatment that was required on any adjacent teeth or opposing teeth for 3 years after the implant was placed. My goodness, they find more ways not to pay. So what I want to bring to your attention is that your clients may be dealing with some of these special clauses that the insurance company has dreamt up. So just to understand, this is an additional pressure that they're feeling while they're going through this. So I just wanted to let you be aware that there are some pretty interesting clauses that they're putting, and caveats that they're putting on dental treatment with regard to their insurance. So let's review how educated our client should be. Our client should be educated if you're not an all in-house type of situation. Let's say you're an independent practitioner and you're dealing with their dentist, then their perhaps surgeon who's going to place the implant, which may end up being a periodontist or an oral surgeon, or a general practitioner whose area of focus is implant dentistry. So they need to know what to expect when they get to that office, who they're going to meet. Sometimes you have a key person that you're going to be able to refer them on, a treatment coordinator or someone, some liaison person that works with your office to make sure that your clients are treated with the utmost of care. And so we want to set professional expectations about the procedures, and then we want to set expectations that the client has on what their self-care is going to have to be through this process and when they have their implant installed. Okay, so just going through those things will make it them feel more prepared. So as part of the dental hygiene assessment, here are the areas of focus that we need to be able to comment on. If there's some concerns, it's really great to bring those concerns to all the parties involved in the implant team. So as far as our client goes, we want to respect their expectations We want to make sure that they have a reasonable thought of how much time is going to be involved in this process. Sometimes they come with timeline goals. Like, for example, they might say, oh, I have a wedding in like 12 weeks or 16 weeks, and what's going to be my prosthodontic situation at that time, or they are going on vacation and they want to know where they're going to be at during that time period. So you may have some of these timeline questions that you have to deal with. Then they're also going to be wondering about cost. It's a stage thing. Every implant has a different cost. There is parts cost, there is timeline costs, and there's different procedural costs. If they need bone grafting or a sinus lift or tissue grafting, that all adds to, of course, the cost. And like I explained to my clients, that it doesn't all happen at once. Fortunately, there's healing time involved, so you do get to break that up, but for some of them, they're going to have to make arrangements to cover that cost. Now, the next thing they have to deal with is their own fears. And for some of those clients, they have phobias and deep-seated fears about having dentistry done, and you're going to have to assure them and perhaps guide them as to when they are having their conversations at their surgical consult, whether they need IV sedation or oral sedation. What kind of level of comfort do they need besides local anesthetic? And of course, some of them don't freeze really well, so you need to advise the surgical doctor about that. Perhaps you need to also deal with their just, they don't like dental noise, or they don't like dental smells, or a wide variety of issues seem to crop up. So we need to make sure that those are mentioned on a referral form, or if it's an in-house situation, then you can communicate with the doctor that's going to be doing that surgery that here are some areas of concern for this client. Pain and fear is like a huge barrier to getting dentistry done, as you know. So we want to make sure that we hit those markers up front, and we can pass along that information to whom it needs to go. Then the considerations for the prosthodontic aspect of the situation, like if it's in the anterior, are they going to have a flipper, or are they going to have a temporary bridge, or what kind of situation is going to be best for that particular client to have in process. So and what's going on with the adjacent teeth? Is there any way that we can make sure that those are in good condition? If you're going to replace when you replace that particular tooth with an implant and it has a crown, is there some maintenance that needs to also be tended to, say, on the distal side of the tooth preceding, because maybe that restoration, as you find out now, is leaking, and perhaps to make the best fit, we need to have that updated. So the other area that we might want to also look at is their night guard. Are they wearing it? Have they not been wearing it? Is that one of the reasons why that they've had problems? Is there a parafunction issue? So those are all the client concerns. Like, are they going to be able to, wear their partial or have things that they've been doing up until that point? How is that going to work in with the schedule with the implant? Okay. So the next portion about our assessment that we need to document and assess and evaluate is their general health. Are they generally healthy? Are they a diabetic? Are they under control, or do they have time periods where they tell you they've been running a bit high lately? So having that information all relates back to healing. This is very important information for the surgical doctor to know. So we need to know what they're being treated for, any current conditions, and what is their status on those conditions. Do they have rheumatoid arthritis? What kind of medications are they on? Making sure that you have a full gamut. You may have reviewed their medical history at the beginning of the appointment, but you need to go through it again and make sure that they haven't done one of those, oops, I forgot to tell you, and I'm also taking, Fosavance. Because I don't take it every day, I forgot to tell you. So then you need to know those items and make sure that you have a fully compiled list of medications. And any complications that have arisen in their dental history at your office, it's good to have a view of those and make sure that they wouldn't also need to be considered during the process of implant therapy. You want to kind of gauge their stress level, because as we're finding out more and more, stress has a great deal to do with healing, and we want to make sure if we can aid them in any way and assist them to, complete calmness or reduce their stress in their life while they're having this integration process of the implant, will aid in better healing, of course. Things like smoking, of course, always come up. This is another red flag area that we need to make notes on. It doesn't mean that it can't be done, but there are certain risks involved, and we need to identify those risks so everyone knows that this is a risk factor. So the next section would be reviewing their dental history. You know, their previous experiences, as I alluded to before. Maybe they have heavily restored teeth. Maybe they have quite a few root canals. And this is just but one that has now come to an end. You know, and we've all met certain people whose bodies just don't deal with the root canal therapy very well for some reason. The residual bacteria seems to, continue to eat away at their tooth and their bone, and perhaps as a procedure in that individual, it's not a great course of treatment. You also want to look at other missing teeth. Why are they missing? What happened to those teeth? And consider in your appointment process, are these going to be involved? If they now have to have one implant, would they have two? Then maybe it's only one time to go to sleep, or and save some money with the anesthesia costs and have two done. Or is it the situation where they have they've had a poor experience before because they had an implant and perhaps they weren't fully anesthetized, and they had a definitely frightful time during the last moments, and so that needs to change. And perhaps your client's changing from one surgical doctor to another to get away from that experience and hopefully lay down a positive experience. So previous dental experiences are always important, and the way that their body metabolizes medication, local anesthetics are very important in the decision-making process leading up to implant therapy. Of course, addressing anxiety and fear is also part of our big bowl of things that we're going to deal with. It may be related to previous dental history. It may be just related to the thought process of having some piece of titanium now put in their body, that they view it as a foreign object that should not be there. And we can talk about it in the terms that we used last day, like an artificial root, so that perhaps that sounds a little bit more comfortable than the titanium screw. But for some people, they would rather it be just what it is, a titanium piece of metal that is going into their body, that's going to assist them in fixing up this space and giving them something very strong. Perhaps we need to also address some underlying medical issue that is causing them fear. So perhaps they are a nervous person anyways, and that's the way they live their lives, but this is going to be also a concern. Perhaps there are other medical considerations that would affect the outcome, and those are all should be listed for your surgical doctor. The reason that we want to do that is, I don't know if you've ever seen, but there are extensive patient information and release forms that are generally signed regarding implants, and their success is certainly in part to the preparation that has taken place prior to by both the surgical team and then the client. Of course, then we're going to review their oral health. You know, they have hopefully been your client for quite some time and you know them quite well, so you would be able to identify if there are any oral habit issues. Oral habits like pear function that can be certainly a contributory factor for them to have gotten to this particular point. You know, I have quite a few clients who we make the night guard and they have the best of intentions, but when I ask them, are you wearing your night guard? Well, it's not all the time, or I was on vacation and then I heard that big crunch, and that's all leading up to indicating factors that perhaps they're, you know, they have a heavy bite, they have complex dentistry. We're going to have to watch if they have some type of systemic reason that they might have parafunction. As we now know, with some medications and some anxiety disorders, they can have micro a parafunction that's so small and so tiny that we may not be able to visibly see it, but we can certainly see the results of it in their oral cavity. Some people I've been able to recognize from whether they have areas of wear on the sides of their teeth from chewing gum. You know how some people chew gum and they tend to roll it in their mouth over and over. And what I've been seeing is certain types of abfraction. It seems to be smooth, and it can be even on the linguals, and it can actually wedge out quite deeply underneath some of those maybe an edge of a crown or something, and in my process of trying to figure out when they're doing it, because, well, I'm wearing my night guard every night, it can't be that, and then I ask the big question is, are you chewing gum? Yes, I chew it all the time when I go play golf. Oh my. Well, I wonder if we stopped that gum chewing so that you weren't rolling that around and applying that type of pressure, that we would see a reduction in the ongoing continuation of the damage of the abfraction. And when I had a couple of these clients stop chewing gum, all of a sudden the abfraction stopped appearing. Once it was repaired with a restoration, we were then seeing it stop. It was wonderful. So these are things you need to keep in mind and be asking. You want to see if there's scalloping on the tongue. Maybe that's going to show you that they're having some parafunction also. So these are good things to know, because once we get to the point where we're putting in the implant and there's no periodontal ligament, there's no cushion for that implant, and you have to think it's biting on another tooth opposing it that has a periodontal ligament. So the opposing tooth is going to have a lot of problems if we don't get the bite just right. I wonder, we should also be making sure that all the current recommended restorative is complete, or should be complete by the time we're looking at the addition of the prosthodontic portion of the implant, because that all relates to bite. And as we know, bite is very, very important to get that right on, or we're going to have some significant issues. So the other thing we're going to have to look at is the availability and quality of bone. So if your client is on a drug like Fosavance, or is experiencing osteoporosis or osteopenia, that would be a great thing also for the oral surgeon to know. We want to make sure we're looking at the trabeculation and that it is in good shape, or perhaps it needs some enhancement. So we're going to have to look at that. You know, it's not for us to decide, but it is for us to make sure that we've made notes in our charts about what the bone quality is like, and if we've had other serious issues of pocketing. So a periodontal evaluation is another key thing. So one of my clients was missing the 1/6. The 1/5 is now hanging in the breeze. I'm not quite sure why it's still there, but it's still there, hanging in. And this client is a smoker and a bruxer, and so the 1/5 is therefore probably going to be removed. The 1/4, because the 1/5 has been left in so long, is also experienced traumatic bone loss, vertical bone loss, and it has a moth-eaten appearance in the bone on the mesial of the 1/4. So if the client is going to invest in an implant for the 1/6 that is missing and the 1/5 that should be missing, perhaps looking at the value of the 1/4 and its longevity in the future care planning is something that needs to be considered, and perhaps a recommendation on your part that it is the prognosis is poor on the 1/4 might at that point have people thinking, well, maybe we should put in 2 implants in the 1/6 and the 1/4 area and do a nice implant bridge, because the forecast of the future of the 1/4 is fairly negative. So these are the things of why, these are reasons why it is significant that we consider doing the periodontal evaluation with stating a type of prognosis for some of those teeth to be a valuable piece of information for treatment planning from the surgical doctor's point of view. We also need to make some notes on their oral hygiene. What's their status? Are they generally compliant with doing home care or not? Because things are about to get a little bit more complicated. So we need to make sure that they understand what the outcome will be as far as their commitment to oral hygiene. And we also need to make sure that we've commented that their oral hygiene status is generally poor, or it has been worse lately due to some particular reason. We need to make sure that we have marked down the commitment, because that may affect healing rate. It may affect the success of an implant. So these are things that we need to specifically point out to our surgical doctor. Any heart issues, so we have a full list of red flag issues that are key to pointing out, and healing potential. If you've known this client for quite some time, you may be aware that their healing rate is slow, or perhaps on the other hand, you might be aware that their healing rate is good. We visibly see their healing rate often on their arms or legs, with, if we've seen them over time and they've had endured injuries of, for example, going for a fall, and we see that it takes them an exceptionally long time to heal. And we've seen that also in the oral cavity when they've come in, perhaps because they had an ulcer and it lasted far longer than anticipated. Those healing rate guidelines would be of great interest to the surgical doctor as well. So we want to know bone health, and I've talked about that previously. We of course want to know if they have any drug interactions, any allergies to medications, and if they've experienced any type of excessive bleeding. Excessive bleeding, of course, is going to be certainly a concern. So we would need to, these are a great list of red flags, things that you should definitely be bringing to the implant team's attention. So we've gotten this far now, and we get the surgical referral, and we've set expectations, and then it's our responsibility to help coach our clients through this process, because in this process it takes time. We are hopefully going to see them perhaps only once, but perhaps twice during this time period, and we want to make sure that we are advocating for any information that they may need clarification on. We need to advocate for their process, and making sure that if they come to us with a problem, because after all, you have to consider that our relationship with them has been very, very good, and they're more likely to talk to us than anyone else. So if they have experienced any issues, you may receive a phone call or an email, or perhaps when they come in, they'll have a few words to say about how their process is moving forward. And we can also encourage them to be very interested in their own overall body health during this time. Perhaps if they are one who is very stressed, maybe we can encourage them to keep eating all their green and orange vegetables and making sure that their overall body health is at a really great level, looking after themselves, so they're going to get great healing from and great bone integration. Another thing that we are going to be interested in is if it's a maxillary implant, we want to know where is that sinus. So you're seeing here a pan where somebody's sinus is very low, and in order to achieve an implant area, we're going to have to build up some of that bone. So at that rate, we should be able to explain to our clients what a sinus lift is. So perhaps you need to print off some diagrams, or perhaps you can explain it using some pictures, but we're going to look at it together today. So one of the things I'm going to also encourage you to do is, if your surgical referral is outside your office, maybe spend a learning afternoon and go over and watch one of these procedures so that you can see firsthand what a great thing to put in your portfolio. What an awesome thing, once you've seen it, to be able to talk to your clients about it, and that would put it so solid in your mind. So basically what happens is the sinus has down and moved and enjoyed the space of where a tooth once was. And so, perhaps now we need to lift it up so we have a spot where we can place an implant. So our goal would be then to be able to add some bone fill in order to increase the height of the bone and kind of slip the sinus floor up a little bit so that we would be able to achieve this event. So basically what happens first is they flap the tissue back. You can see in this particular picture it's quite high in the vestibule there, and you're going to expose the lateral walls of the sinus. So you're going to use a piezo to go through that wall of the bone, and then there is the membrane that is elevated. So if you think of the membrane like an orange or a grapefruit that is in between the sections, it's a very thin, fragile membrane, and you're going to separate that off and lift that up. And then what the surgeon then does is places a whole bunch of bone grafting material in that section, and at the same time or a different time, it's going to depend on the surgeon's preference, can place the implant and pack all that bone fill around the bone grafting material around the implant, and then they're going to then place a membrane over top of it and then suture it up. And you're going to be able to see over time that it will create a wonderful spot for the implant to be placed in, some bone grafting material, as well as lifting the sinus up out of the way. So it's really great for you to be able to see the end results once that's all sutured up, and then that could create a wonderful transformation. As you see, this client ended up with a couple of, quite a few implants, but some sinus lifting procedures so that they could have room to place those implants. Our next thing that we need to evaluate is our tissue evaluation. Certainly we need to see whether the tissue is scalloped, normal, flat, where there's keratinized and non-keratinized tissue. Now we do know that an implant is much more successful in keratinized tissue. We want to know where the attached, the unattached, and the free gingiva is, and we want to know where the demarcation line is. And why do we need to know all that? Well, we need to figure out whether we need some tissue augmentation to our particular client's situation. In the soft tissue evaluation, there are two biotypes. One is a thick biotype and one is a thin. The thick biotype is a more fibrous, strong kind of tissue that is paler in color, and it is overlaying very good thick bone, generally speaking. Okay, so it is more resilient to trauma, and those biotypes are really great. And the way you can check that is that you can't see the probe underneath the tissue. So that's why I've showed you this picture here. In a thin biotype tissue, you can see the probe underneath, and it tends to be a more scalloped appearance. You can actually go in the vestibule and feel the roots underneath the tissue, so you know the bone is thinner. There may be fenestrations and dehiscence present. If you lift everything up, it is definitely more susceptible to trauma. It has a greater ability to resorb on you. So just noting of whether this is a thin biotype or a thick biotype is something that should be considered. Perhaps if you're going to do any tissue augmentation, it should be done prior to the implant. So if it is an area where tissue is very thin, perhaps a grafting procedure should be done before. And I've got a picture for you here. You can see that a graft was done, and you can definitely see then that the implants benefited from more keratinized tissue there. So the other area that has to be considered is bone augmentation. Perhaps there needs to be a socket preservation. If you're going to slip out the tooth first, and then you could place bone grafting material in that zone. Perhaps it would be also aiding in an area where there was a lack of bone that was seen, like for example in this situation here, so that when you go in 6 months later, you've got a great area to place an implant. So this could be termed as socket, or if it was a ridge preservation. One type of bone augmentation. The other type of bone augmentation would be if it was a block in a certain arch or a certain zone. You might see that. It can be either from human materials, bovine or synthetic. And really the purpose is to repair a periodontal defect, or to augment into a socket or a ridge, put in extraction sites. So this is the benefits of bone augmentation. And in this particular pan case that I'm showing you, you can see that certainly there needs to be some bone augmentation in the upper right. This particular case is about a client who had previously had implants placed, and unfortunately they had failed. So when those implants came out, there was even less bone there. So some bone augmentation did have to take place, and the next images are of the treatment planning. So we have images from the CT, and we are showing where the implants were going to be placed. And the cone beam radiographs are very important to utilize, and in the planning there's lots of details going on, and certainly you can get the programs that actually tell you where to place the implants. It's just really cool for us to be able to see all the information that is used in the treatment planning process of an implant case. So you get some great results, and you can see in this pan how there is bone fill, bone grafting material, and good integration of the implants. And then on her wish list, another step-by-step process leads us a few years more to get some more implants so that they have great support all the way around in her mouth. She has great posterior now support so that it's not so waning on her anterior teeth, and she has a great functioning bite that is working out really well for her, and she couldn't be happier with her results. So it's a fantastic step-by-step process. It all takes time. It doesn't happen overnight. And through, it's probably been about 5 years, I would say, that it took us to get to this extent in this particular process. So it is something that moves along at a special pace. And I just wanted to talk to you a bit about a new product that Straumann has come up with, Endogain, and it is different from the traditional bone grafting materials. This is actually a product that stimulates the development of cementum, periodontal ligament, and alveolar bone in some recession areas, and can be used in certain zones. So I'm not saying that it's a part of an implant process, but I did want you to understand that there are new products up and coming that may be integrated into the implant therapy process or the repair on a tooth that is adjacent to an implant site, and they're not all the same. They are changing in abilities all the time. So we need to be aware of these upcoming and newer types of materials that are being used. I think it would be great as a hygienist who's dealing with whether an on-site surgical doctor or a referral surgical doctor, to understand the comfortable procedures that that surgical doctor likes to do, and understand the products that they use and the systems that they use, so that you're able to talk very intelligently with your client about those. So if your doctor tends to use Zimmer or Straumann, you should learn about their particular attributes and why that doctor chooses those, and what types of bone grafting material they like to use, and understand those products, because it just makes us more valuable to the implant team, and it also aids us in being a valuable asset and resource to our clients. And in turn, that relationship that we have with our clients gets stronger, which is what we get to enjoy, to develop our own practice within the practice that we work. So just to then press on, we've got our surgical process beginning by the surgical doctor very carefully, gently, and skillfully removing any hopeless teeth, and then evaluating the socket and making sure there's enough material present, or augmenting the material that's needed to be present, checking the availability and quality of the bone where the implant is going to be placed, and then placing the implant. Some doctors might also use PRGF, which is protein-rich growth factor, which is actually from your client's own blood, and may be harvested and utilized to mix with bone grafting material to aid in healing and quality of healing and the speed of healing. So if the surgical doctor that you deal with does that, so you should learn more about that process so that you can thoroughly explain and discuss that with your client. As part of the surgical process, the next thing that we're going to look at is the type of implant that is being placed. There are tons of them out there, and there are two like major levels or discussions of implants. Basically, is it going to be bone level or is it going to be tissue level? So bone level is great because it's the most aesthetic choice. You can place it anywhere, but certainly in the aesthetic region, that's what you're looking at. It's placed at the crest of the bone. Sometimes it requires a second surgery to expose the top of it, or it has to have a healing cap placed on it. And then the abutment and the margin for the crown is basically at or just slightly subosseous. So that's a bone level implant. Now we're going to talk about the tissue level implants. They're most frequently in the posterior. They can be, they have a smooth collar usually. They can be tapered or wide-necked, or they have different designs. All implants have threads and are textured. The ones that are more textured, the idea is that think of it like this stuccoed ceiling. I think I talked about that before, that it just gives you more surface area when it's more textured for the bone to integrate into the implant. So these are placed at the level of the crestal bone, the crestal edge, with the collar exposed through the tissue. And there seems to be a decreased chance for bone loss around these because, of course, everything is at the crest of the bone and not like at the bone. So, well, it seems to be that it's a little bit safer in dealing with, if you're dealing with cement. So anyways, it's good for you to know what the differences are between a bone level and a tissue level implant, and hopefully you can challenge yourself and look at some radiographs and pictures, whether it be online or in your clients, and work on being able to identify that. Certainly there are a multitude of things to think of when the surgical doctor is thinking of what type of implant, the length, the width of implant that is going to be placed. Obviously, the digital imaging that is available to them in treatment planning, their visual inspection and palpating the actual bone itself so they can feel it and look at it, probing that area. Of course, I alluded to before, the computer-generated treatment planning that is available, lots of programs out there that some of them, this is one of the areas that hygienists are now edging into, is being that treatment planning and facilitating and working with some of these digital planning areas. Very interesting area of practice that might be of interest to you. Of course, evaluating the bone in terms of height and width and thickness. The adjacent roots have to be kept in mind. And of course, then, like I was saying, in the manufacturing of it, there's the different types of surfaces that are involved in those. And of course, then there's good old operator preference, because, we feel very close to some instruments and not so warm and fuzzy with other instruments. We ourselves can make certain ones work best. You alone on a desert island sort of thing. You could work a particular instrument to your heart's content, and certainly in the surgical process, those docs are developing their preferences as well, and what works really well in their hands. And that's why it's really valuable to pay attention to those referral letters when they come in from this periodontist or that oral surgeon, or whether it's in, and seeing what is preferable to that surgical doctor's placement. Of course, then we need to discuss with our client and plan for some prosthodontic consideration of what the temporary is going to look like. Is it going to be something like we're going to utilize the coronal portion of the tooth that just came out and bond it to the back and sort of do like a little bridge thing, or are we going to have a flipper, or what exactly, or is the client totally fine with walking around for a few months with that little space there? If it's in the molar region, maybe it's not an aesthetic issue. So, you're going to have to figure all those details out. Then we need to make them aware of their healing, that they have a big piece to play in their healing, and we're going to encourage them to be aware of their overall health and their nutrition and their self-care, because certainly we don't want an area not having good oral hygiene. So usually chlorhexidine is something that is well utilized during the process of the implant therapy. No one likes all the stain, but it certainly does aid in healing and help them get to the best possible way when they're trying to maintain those areas. Okay, so we're going to define osseointegration. It is when the living bone is actually attaching to the implant. And when you've reached the absence of mobility, then it has been integrated. So as you can see from our integration process that is on your slide there, you can see how over time that it integrates into the bone and the implant threads. And so it becomes more and more steady as the time rolls on, as the months tick by. But it is considered integrated once there is a lack of mobility. So we need to wait that time period, which is going to be different for everyone, like counting days. So they usually group it into terms, and then they're going to perform what they call a torque test, which is when the surgical doctor is going to try and see if it moves. So implants are able to be loaded anywhere between 8 and 12 weeks. And this is what I say, and perhaps even longer if perhaps you have a medically compromised patient, you want to wait a little bit further. There is loading at that 8 to 12 week mark. There is gradual loading and immediate loading. So if the surgical doctor and the restorative doctor you're working with deals with gradual and immediate loading, that's really an operator sensitive time frame. So you need to spend time with those doctors learning about what their own protocols are and what their comfort zone is. So the other words that we need to be able to understand are the perimucosal seal. So the perimucosal seal is that barrier that is the circling tissue around the implant. It basically divides the inner and the outer world, much like marginal gingiva. Okay, so we want to make sure that that seal is so important to hygienists. That has to be in good shape. If there is a lack of consistency there, then the biofilms are getting underneath, which we don't want to have happen. So this is a particular area of focus for us when we're doing maintenance. We need to make sure that that seal's working. I thought it would be great to show you a visualization of the difference between an implant and a regular tooth. So what we've got pictured up here is the way that it is the implant is integrated, and that you see that there is connective tissue not attaching but aside the implant, whereas on the tooth you have the Sharpie's fibers. So I've made you this little chart that shows you the similarities, which there aren't any, and the differences, of which there are many, between the artificial tooth, the implant, and the regular tooth. So the fibers in the connective tissue run parallel to the implant, as opposed to the tooth, they're more perpendicular. Well, they are perpendicular. So I made you this little chart just so that you could discuss that with a client if they're in that scientific mode and they want just a little bit more information. Then you have some key points here that you can go over with them about the way that it works. And it's really good for us to know that you can get pocket depth between 2.5 and 5 millimeters, which would still be considered healthy, depending upon the situation, provided there's still no bleeding and that it is gingivally sealed, like the tissue is all sealed on the inside. Sometimes you get that sort of like an overgrowth of tissue, especially around areas where you have implants that have bars on them that are perhaps attaching partials, or I mean dentures. I mean attaching dentures too. So you may see that. So just know that that still falls within the bounds of normal. Now I've put up here in the Maintaining and Evaluating of Implants, the International Congress of Oral Implantologists logo, along with the auxiliary and dental of the ADIA's logo. And these are great resources if you are looking for some question to be answered. I would suggest that this would be a great resource, a group of people that have tons of meetings, and certainly I've been a part for quite a few years now that give you great implant protocol information. So they have a website, and they certainly have a great membership. It's very inexpensive, but it certainly provides you with ongoing information regarding how implants are advancing and how that all works. So something for perhaps you to look into. When we're dealing with implant maintenance, periodontal disease pathogens are invading. If they are invading into the tissues, that would be called peri-implantitis. When we're dealing with implant maintenance, we need to understand that periodontal disease pathogens are the same that are associated with peri-implantitis. So we have to be very careful to be checking over when all of the areas of the tissue in order to avoid some mishaps happening and periodontal disease happening to our implants. Okay, so the next thing we're going to go over is implant maintenance assessment checklist. Okay, so we're going to create a checklist for yourselves of what you need to be doing when you see your client and what the areas of focus should be. Okay, it's not that much different than when you're doing your assessments of natural teeth, but there are certain things, certain little details that you need to be crucially aware of. So those things would be to review their medical and dental history. And when you're reviewing their medical history, are they still in control with their diabetes? Or have they had trouble controlling something so that perhaps that influence may be seen? Perhaps they've been on some steroidal treatment, and you're going to have to keep that in mind when you're evaluating their tissue. Has there been any change in their dental history? Have they had some dental work done outside this office or when you've seen them last that may be affecting, say the opposing tooth had to have a root canal? That would be really good to know. So you want to check in their oral hygiene habits. What products are they using? Perhaps they're being effective, perhaps not. Perhaps something is scratching, or perhaps when you see that there are some little threads that are caught underneath their implant. So there's a wide variety of things that people use to clean around their implant, from things that are rubber, like say soft picks, to even yarn that's been soaked in chlorhexidine. So you need to make sure that you have a pretty clear picture of what their oral hygiene regime is, so that you may check carefully what they may or may not be missing. So they may be missing, or they may be overdoing and causing some damage to the tissue that seal around the tooth that we are trying to keep in such awesome condition. Do they have a chief complaint? Has there been pain? Has there been a sense of being solid, like I don't even know it's there and it's perfect? Or has there been some concern? It just doesn't feel right. That would be some of the things that people might say. The next in your checklist is you need to know what kind of implant you're looking at it. If it's a subperiosteal implant, is it just a root form implant? There may be a screw retained type of prosthetic, or it could be a cement retained. So if you see that it's a screw retained, is the screw loose? Or is it got cement around the neck if it's a cement retained crown or bridge? Or is it an overdenture and perhaps the little rings need to be replaced? There are many types of prosthetic devices that you're going to be seeing, and you need to know how each one of them works. Then we need to go back to our gingival evaluation. So we need to look at color. Color always tells us something. So we can tell if there is an infection going on, or perhaps they're not being effective with their oral hygiene. Perhaps it's going to be that the tissue surface has changed. Perhaps it's gotten fibrotic, or perhaps it's glossy and it's hiding something underneath there because it's now swollen. You've got the edema. Perhaps it's the shape and the size of the tissue that alerts you to something being wrong. Is it enlarged or cratered? Is there something that needs to be attended to? If it's a change from baseline, then we have to write that down. Is there any bleeding? Is it their spontaneous bleeding with pressure? Do they get bleeding when they're doing their own oral hygiene? That would be causing some concern to me. I would want to investigate further. Is there enough keratinized tissue? If there isn't enough, perhaps we need to deal with that, because we might be that the client comes in complaining because the non-keratinized area is so sensitive when they're brushing. And perhaps then it means that there's a little bit of the thread showing. So you can see in this picture how after a graft was done, the tissue looks a lot more resilient and will stand up to the self-care regimen that the client would like. We then have to evaluate the inflammation. Is it marginal or diffuse? Which one is it? And we need to make sure that we've noted all those issues down. Do we have a probing depth? And is it the probing depth causing bleeding, or is it the same? Are we monitoring correctly? And don't worry, we're going to go through to probe or not to probe as we get further along. So is there any type of pus coming out of that area? Is there something that's calling us to assess it more thoroughly? Usually all these pictures that you've seen would have us having our attention focused on this zone, knowing that there is a problem that we need to investigate more. Then we need to do a radiographic evaluation. Are the areas the same? Are we losing any bone? Are we monitoring it correctly? We need to take radiographs to monitor so that we can use the threads to aid us in identification of areas of concern. Usually, they say ideally it would be the same clinician in the same room with the same setup to do the radiographs, because that would just make it all the more consistent and easier to evaluate. Although this, doesn't always happen, that would be the ideal. So then we have to evaluate the prosthetics. Is there some, component that is loose, like we talked about the screw, or is the whole implant in this particular case that you're looking at came out? Is there perhaps something to do with the bite that is causing a shift or a chip or a wear mark on the crown of the installed implant, or even perhaps pressure on the opposing? So we need to be able to evaluate that. Is the home care of the removable prosthetic, have we been clear enough? Is it being effective? And can we make any changes that is going to make it better for the client? So we are also going to evaluate mobilities, And is there any hard and soft deposits that should be removed from the restoration? We have to develop some really good doable client goals for oral hygiene. Let's keep it simple and be effective, and make sure they understand that they don't want to take a proxy brush with the wire that has not been coated and go at it and scratch the edges. That we want to be more subtle, and we want to be careful not to scratch, but we want to be thorough to clean. So, and are they getting anything stuck in there? Like with the great bread that's on the market that everyone loves to eat, those little husks and seeds, is there an area where something's getting caught? Is there a fold in the tissue or something like that that you need to educate your client on? Or perhaps there needs to be some surgical intervention from a periodontist to make that area more self-cleansing. So you're going to discuss all those clinical findings, and you're going to document the whole thing, and you're going to make a referral if you need to make sure. So one of the things that I think you should know about is if there was mobility, there is a device that's called an Austell device that measures mobility. So it aids in being able to give a gauge. So it's called an implant stability scale. So you can test the mobility of an implant. So for people who are doing gradual or immediate loading, this device is key to their practice. In some practices you may not see that, but it can be used to it actually measures the mobility both from a mesial distal viewpoint and from a labiolingual viewpoint. So it works on micro motion, and it has a scale. So it's an interesting device to understand that it exists, and if you get to, if your office has one, to use for monitoring implants. So I thought you might be interested. If you haven't seen one before, then you at least know how it works and that it's out there. So today we have laid the groundwork in discussing the process of implant placement, and we have also discussed the checklist that we must go through looking at tissue when we see implants on their return to us for maintenance. And next time on DVD Quarterly, we will be going through implant protocols for maintenance, and that will be discussing how to maintain with what instruments, what is recommended, the self-care goals that we could set for our clients, and what products are out there that we could use. And we'll just review how we should monitor those implants. So we'll see you next time on DVD Quarterly as we expand our knowledge on what we should know about implants.
Dental Implants, Process of Care, has been presented by Anna Louise Tolan, RDH.